Mr. Rayhan SS, speaking about healthcare and educational needs of young children. Time to deploy SDG roadmap in public schools of Telangana. And Mr. Rayhan is joining us from Oak Ridge International School, Bachpole, Telangana, India. Over to you.
First of all, good afternoon, everyone. I'm Rayhan Shanavas from Hyderabad, which is also known as the Pearl City in southern India. And I'm honored today to discuss our work from Synapse Foundation, which is an organization that I co-founded. And this is specifically conducted on school children from public schools, what we call government schools in Telangana. So today I'll be focusing on healthcare and educational needs of young children. And this is in relation with the Sustainable Development Goals. So I'll be segmenting my presentation into 4 parts. First is the background, the methodology followed, the results, and finally the discussion. So first I'll be going on to our background and hypothesis. So the subject of our was around 418 million children in India, which is approximately 20% of the world's children. Thanks to the excellent work that was led by the Indian government and the encompassing public policies, passing of legislations, and untiring efforts of many, most of these children can be found in schools and has a gross enrollment rate of almost 100%, and this specifically in the elementary zone. So there has been multiple initiatives with targeted focus and enrolling a larger community having been undertaken over the past few decades, as you can see on my slides over here. Of these, the midday meal programs which are conducted was basically by providing lunch to government or public school children. And this is by far the most touted one globally given the scale. And these are, these will continue to improve the Indian conditions. But let's see what has been, the very 400 million children that we're focusing on. So despite the tremendous efforts, the graph that you can see over here highlights the concern gap. Even though, as I said, we have been able to attain almost 100% enrolled in primary schools, the secondary and higher education state is still dismal. Additionally, while we don't have national level data, it seems that the majority of these students are not entering into the organized labor force. Now, combined with this with the fact that every third malnourished child in the world still lives in India, every second Indian child is underweight, and every second Indian child is also anemic. So clearly there is work to be done. There are gaps that still exist. So what is our way out? Let's go back to where the children are, the schools. So as you can see on the 3 pie charts that are there on my slide over here, first, India has more than 1.5 million schools, and most of these include primary, majority of them being in the rural segments controlled by the government. This, according to us, is great, but it's still underutilized as an opportunity for the country. Now, why do I say this? Well, the 2022 to 23 Sustainable Development Goals, that means SDG report for the country India, was published last month. It's impressive progress with a score of around 71, but let's just see the legend over here. Though the screen looks positive, it actually doesn't mean 100%. It actually indicates front runner and not achiever. Front runner meaning that it's almost just above 65%. So while all of these initiatives are leading to a positive trend and many SDGs are still being met, the 4 core SDGs that are affecting children, that is inclusive of SDG 2, which is zero hunger, SDG 3, which is good health and well-being, SDG 4, quality education, and SDG 10, which is reduced inequalities. And for women, SDG 5, which is gender equality, all of these are still significantly lagging behind in India. The concern is not just at the international level or the national level. We don't even have a single state that could achieve the target 100%. Now, definitely there's been progress in all of these states. And as you see, there are around 3 SDGs on my slide with 3 maps of India, each showcasing the progress of the SDG. So even though you can see a few greens, a few reds, and a few yellows, this just points out to the fact that there is an issue both local and systemic, and second, that it warrants detailed evaluation in a region-specific manner to make any central policy or intervention successful. So though it may seem that there's been a lot of progress, there's still a lot of disparity among the states in achieving even 100% of any one of the goals. So studies so far have shown major risk factors to the growth and development of children, as it's indicated over here for risk factors and impact. First, I'd like to go over like the skipped meals and poor diet, where it relates to the food security that's a problem with leading to poor access to nutrient-rich food. And this could lead to an underdevelopment of cognitive development and malnourishment. Traditions and cultures of the place also are severely in place, though it is still not as present in urban areas. It's also still present in the rural areas, which represent majority of India's population. So traditions and culture of the place, example for visiting the health clinics means like a disaster, and thus avoiding food or supplements if the health centers are nodal points or communication points. There's also low awareness and strong social conservatism, which means, heightened sensitivity and stigmatization to break the circle of poverty, unless, the person, he or she is a prodigy and medals flow into the house, or, a monthly, if not weekly basis. Lastly, as you can see by the SDG 4 quality education icon, a complete financial and psychological dependence on government for their children's education. This puts the children at a great disadvantage, as schools currently don't operate as sole players and are expecting heavy partnership from either organizations, parents, or it could be governments. So there's a sole dependence on the government. So this could have a major risk factor also. The impacts of these risk factors, if few or all play out, are vast and long-lasting, ranging from malnutrition to early onset of chronic diseases, and even could lead to poor morale and continued intergenerational poverty in India. Which brings me to my next slide. This brings us to the place what we chose for our study. Telangana is a newly formed state which was formed in 2014, only 10 years ago, and it ranks higher than many other states as well as national average in terms of attaining the Sustainable Development Goals. Yet even Telangana couldn't hit the positive 100% note for children. Thus, we hypothesized that poor access to resources, both public and at home, combined with socioeconomic and cultural practices, are impacting physical, metabolic and psychological health of children and hindering attainment of the Sustainable Development Goals and their impact in India. So, this is what we hypothesized, for our plan. And now I'm going to move on to the second part of my presentation, which involves goals and the methodologies that we followed. Now, we started the study with 4 broad objectives. A, assess the presence of different risk factors that are present that I mentioned earlier, assess the health status of students and define prevalence of malnourishment indicators, and then hopefully align on the critical needs. That means forming goals for them and levers to aid in designing potentially effective interventions that could take place. So as given by the titles, risk map, health status, holistic needs that need to be identified, and the interventions that we could possibly take place. Now, similar to the epidemiological study, we adopted 4 key steps to our study. First, we chose the suburban regions reflecting urbanization, a relatively lower socioeconomic segment. We adopted the WHO stepwise, as well as All India Educational Survey, which was then used to collect data after obtaining the informed consent. Post-cleaning of the raw data sets descriptive statistical analysis, and it was conducted using the SPSS software. So what did we find? This is moving on to my third part, which is the results. Now, as you can see on my slide over here, in a sample of 460 students from 2 primary schools, we observed that 55% were boys and 45% were girls. Most of the children were in the age bracket of 7 to 12 years, with a slightly higher spread across compared to the class-wise average that's been in India. That means enrollment is usually at 6 years, and thus ideally 6 to 10 years spread was to be observed across grades 1 to 5. The data indicates that, in the real world, the enrollment age is actually higher, and thus ranges from 6 to 13 years. Missed school years due to seasonal or long-term migration, that means you're missing school, was found to be another cause for this. While not alarming continually, it has a continued focus on enrolling girls and transitioning children into school earlier in pre-primary school as needed. So now, for our goal to understand the health status of these children, specifically focusing on the health aspect, we found that more than 50% of the children were actually unfortunately anemic, with 12% belonging to the severe category and 49% to moderate category of anemia. This prevalence across age groups seemed to, let's just say, it was seen to be similar to the percentage of severe cases that were lower in 6 as well as 11 and 12-year-old kids, 12-year-old children. We then tested the anthropometric measurements as a tool of malnourishment. That means the height and weight were taken and compared to age-matched Z charts that were published by the WHO. This indicated that the mean height of boys was statistically significantly higher than the girls at most age groups till age 10. Now, the percentage of stunted children, that means those who have less than 2 standard deviations of the normal height, were significantly higher in the age groups of 6 and 7. That means 56% and 68% of ages 6 and 7 respectively were actually stunted. So similarly, using the WHO charts for underweight categorization, we observed that the mean prevalence of underweight, that means again 2 standard deviations lower, the appropriate normal weight was 57% and 59% in boys and girls respectively. There was no significant difference in the body weight between boys and girls across age groups, while the stunting rates ranged from 50% to 71% across age groups. So though these are just statistics, we then went forward to understand diet as a risk factor for health, connecting it to what we did. Majority of the children don't have breakfast. Culturally, many are handed over a small amount of ₹5, less than 10 cents, you would say, which can fetch them a biscuit or a chips packet. Dinners are mostly grains and lentils, as we found out through the survey, and later more liquid than of protein, while the weekends get them 2 to 3 pieces of chicken. That is protein, over 2 meals. As can be seen in the graph, none of the food, if you see on my graph over here, none of the food groups are actually adequately consumed by children. There's a lot of disparity in this. Appropriately so, most children rely on the midday meal scheme, which I talked about earlier, but only 17% of the children get a supplemental portion from home if school lunch is even provided. Therefore, midday meals from the government become the key nutritional sources for children during school, as well as for their long-term growth. Unfortunately, because of the dependence, it has been observed that fruit, vegetable, and dairy consumption, even though the midday meal is very limited. So even though there is a midday meal scheme, these are still very limited in terms of that. Additionally, schools where food is not cooked fresh and served hot, the missed meal percentage is very high. This again is a cultural issue because we believe that hot food is considered fresh and high quality. So there's a lot of avoidance that's occurring. As the next objective, we focused on understanding the likes, dislikes, and aspirations of these children. Boys preferred cricket and kabaddi, known in the country as games for men, while girls loved kho and skipping. These are some games. As can be seen in the graph over here, children's preference for the types of sports were indicative of strong stereotyping culture. The preference of reading, writing was low, and art was actually nil, indicative of a potential impact of exposure that's a problem and access to these personality development activities. So about 35% of the girls each preferred to become either a teacher or a doctor. But interestingly, almost 70% of the boys wanted to join the police and armed forces, with only 3 to 4 wanting to become engineers. Boys indicated an inspiration from war heroes, movie stars, and their perception of being strong as drivers for choosing police as a career, while girls indicated they wanted to stop corruption. Most of these children loved languages, both English and the local language Telugu, the latter preferred more by girls. Unfortunately, most children were not very literate or fluent in English because of the access to quality education. So the disconnect between the aspiration to be a doctor and the absence of preference for science could be a lack for the exposure of the subject. So this disconnect has been observed for, as a key driver for dream gap, while children have lofty aspirations, poor access for.
Mr. Rayhan?
Yeah, okay. So children stay close by as 90% of them walk to school. They were willing to attend additional classes or skill programs due to this convenience, and this offers an opportunity to, make school the nodal point for all public policy interventions. So absenteeism is not very high with an average attendance of 80%, and they did not mention fever and stomach ache as a problem. So having visit a health expert at a school or a clinic will allow children and parents to avail this facility rather than going to another medical center. So finally, I want to move on to what is the discussion. So what does this mean for the road ahead? I will continue this to discuss for discussion. So as I go on here, having seen that the health status of children is not in good shape and having identified that the critical risk factors spanning from poor socioeconomic background, inherent traditions, and cultures of a region, we turn to map the critical gaps in public schools that need addressal. As you can see over here, while enrollment and gender ratio is achieved, the support system is broken to yield effective outcomes. While textbooks are provided, notebooks are not. While uniform is provided, basics like identity card, shoes are not given, creating a disconnect and daily reminder of their poverty. Though lunch is provided, breakfast isn't. So this doesn't deliver, sufficient nutrients to the child. Again, while anemia is identified as a key issue and weekly iron supplementation is available, the logistics are complicated. The children and our parents are expected to visit the local health center to take the same, which in many cases is not being followed. So the following pictures will give you a better idea. As you can see, some schools don't have study tables, while others have deficits, making some children sit on the ground and others on the benches, a stark reminder of disparity and poverty every day. Midday meal is the main source of connection with families. Long lines, poor serving conditions reminds the children of their poor state and does not allow them to develop into confident and mentally strong kids. The slide here summarizes key levers that need to be strengthened for impact. Parents expect schools to be one stop, one shop, one that's better than their home for their children, while current policies are considering school for education and meals as a way to entice children. Parents can become true partners if they see true equality being attempted for, like access to better food and nutrition, higher quality education, and visible signs of respite from poverty, like shoes and ID cards for their children, a connected holistic infrastructure for the multidimensional growth, and healthcare obviously is considered to be a major importance. Physical education for preventive care critical at school, and leveraging CSR funds for school and children. So the picture speaks. Parents are wanting to fully entrust their children to the government, but are slowly losing hope. They're relying on the school for complete care and can't afford to add in the form of food or books. In the absence of clear success stories, it's a matter of time until they pull their children to school for labor, this moment they turn 14 years old, killing hopes and dreams for all. School employees are willing to be committed, but they can't take the burden of the entire care continuum. Physical education teachers, healthcare personnel, and even nutritionists or hospitality teams are needed for them to focus on delivering quality education. So whether it's a primary school or a high school kid, they're committed to making a change. They need a system that's foolproof, as unfortunately they don't have the backup from home, both financially and psychologically. So this moves me to my final slide, which is the approach. The Insights has given us both softer aspects and hard measures. Thus, we recommend schools to be better centers of excellence, one that allows the government to implement all initiatives across SDG 2 for food security, SDG 3 for healthcare, SDG 10 for showing true equality and access to resources by giving services across food, healthcare, and education. This requires ramping infrastructure, both physical and manpower, especially subject matter experts. Government should own infrastructure and ensure CSR funds are directed to additional services, not just specific education, but healthcare, breakfast, physical fitness, and digital connectivity for advancements through sectors. This creates transparency across all the players and the policymakers, execution specialists, schools, teachers, and parents, as well as volunteers or corporations that are directed towards impact. Therefore, in summary, by understanding the social cultural behaviors, thoughts, and expectations of parents driven by their economic conditions, we believe we can actually design ideal policies, implement them with the help of volunteers, especially from corporates, and ensure its adoption by children and families towards economic growth. Thank you.
Rayhan? Yes.
Yeah, thank you.
Perfect timing. Thank you. Do we have any questions from the audience? The floor is open. Dr. Pratik?
Yeah, Dr. Ryan.
Yeah.
Yeah, very well presented.
Thank you.
I would like to know what are your future plans regarding the proposal which you have said. So do you plan to implement any of the said things in near future?
Yeah, so we try to make sure that, so what we have done so far is we have gone to certain schools to understand and take surveys. The next approach, for example, is we have tried to get to a company for manufacturing tablets, which are for children for anemia, because we've seen in a lot of the children, they are not taking certain tablets that are prescribed. Like the government has schemes, for example, by giving the iron tablets to children, but because of the taste, the children are avoiding those iron tablets. So what I've done is try to make sure that, we could implement something that's tasty for the children so that it could help them beneficially for health. So that's one aspect. We're trying to make sure that we can connect to different corporations so that they can kind of come together for certain funding and raise funds. And for example, in my school, we raise certain funds for an initiative and direct it towards, the sectors that required, especially not just in the private sector, but also in the public sectors. So we want to take this forward to the government of Telangana. And as I said, this is not going to be easy for us to do because A lot of the plan that we did involved surveying the results. So what we're trying to do right now is give the results to the government and then from there take it forward and connect to companies so that it could strengthen the cause. Yeah.
Thank you. That would be really great. All the best for you.